at the Department of Veterans Affairs. Before we begin, as this hearing is fully virtual, we must address a few housekeeping matters. For today's meeting, the chair or staff designated by the chair may mute participants' microphones when they are not under recognition for the purposes of eliminating inadvertent background noise. Members are responsible for muting and unmuting themselves. If I notice that you have not unmuted yourself, I will ask you if you'd like the staff to unmute you. If you indicate approval by nodding, staff will unmute your microphone. I remind all members and witnesses that the 5-minute clock still applies. If there is a technology issue, we'll move to the next member until the issue is resolved, and you will retain the balance of your time. You'll notice a clock on your screen that will show how much time is remaining. At 1 minute remaining, the clock will turn to yellow. When your time has expired, the clock will turn red, and I'll begin to recognize the next member. In terms of the speaking order, we will follow the order set forth in the House rules, beginning with the chair and ranking member. Then members present at the time the hearing is called to order will be recognized in order of seniority, alternating between majority and minority, and finally members not present at the time the hearing is called to order. Finally, House rules require me to remind you that we have set up an email address to which members can send anything they wish to submit in writing at any of our hearings or markups, and that email address has been provided in advance to your staff. Today, we welcome Deputy Secretary Donald Remy from the Department of Veterans Affairs, who leads the effort to modernize VA's electronic health record system. The Deputy Secretary, who was recently confirmed in July, can shed light on challenges VA has faced implementing the new health record system and findings from the recent strategic review of the program. He can also speak to how VA intends to improve the rollout process moving forward. In 2018, VA began a historic nationwide transition from their longstanding electronic health record system, VISTA, to a new system developed by Cerner that is interoperable across VA sites and with the Department of Defense's health record system. This transition is over 2 decades in the making, and it has not been without its ups and downs, so to speak, as many members know. The new EHR will put VA and DoD on a single system meant to improve veterans' healthcare experiences by eliminating the need to transfer records as service members transition from active duty. Clinicians from both departments will be able to view, update, and securely exchange patient data in the new system, as well as share information with providers in the communities where veterans live and receive care. This transition requires significant time and effort from VA staff and is an extremely complex undertaking. We're holding this hearing today because it is critically important that VA get this transition right for veterans, their families, and for the clinicians who provide the care that millions nationwide rely upon every day. While an electronic health record system is at its core simply software, it is really much more than that in practice. An electronic health record is a tool for clinicians to make their very difficult jobs easier and to inform and improve healthcare delivery and outcomes for our veterans. At the end of the day, this whole undertaking is about improving patient care. The last oversight hearing on this topic, held by our subcommittee, was in February of 2020, after significant programmatic delays and poor communication from VA on the status of the stalled EHR rollout process. Since that hearing, there have been some significant developments. VA's first, and thus far only, go live with the new EHR system took place at Mann Grandstaff VA Medical Center in Spokane, Washington, 1 year ago this month, in October of 2020. This was the first of what is expected to be more than 150 go-lives at VA sites nationwide by 2028. VA had originally planned to go live with the new EHR system at 3 sites in 2020 and 11 more sites in 2021, but there have been multiple setbacks to that timeline. At this point, VA is more than 1 year behind their initial schedule. Unfortunately, the first rollout at Mann Grandstaff has been more difficult than expected, with serious concerns raised by staff, veterans, and external stakeholders. Complaints of lost productivity from clinicians and of inadequate training on the new system have persisted since last October. The Government Accountability Office, GAO, recently briefed our staff on findings from interviews with Mann Grandstaff end users, which showed predominantly negative views of the new EHR system among clinicians and medical staff, with specific concerns on the quality of training provided. Perhaps more concerning are the reports of potential patient safety issues from clinical staff, such as missing information from patient medical histories, which is obviously very serious, which could lead to treatment errors. While there have been no reports of patient harm, thank God, at Mann Grandstaff, this is not a concern to be taken lightly. In March, one of the first actions that Secretary McDonough took after arriving at the VA was to pause all additional go-lives and conduct a top-to-bottom strategic review of the EHRM program, including an analysis of the problems at Man-Grandstaff. Now, I applaud the Secretary for taking this step, and he has been extremely communicative with me, making sure that we are aware of the decisions that they're making at each step of the way. And the strategic review was a useful and necessary exercise that identified many recommendations to improve the rollout. I understand VA is now taking steps to implement those recommendations into the rollout plan for future go-lives. This includes improving clinician training, focusing on change management, and incorporating medical staff from VHA into the planning process. I expect that we'll hear from the Deputy Secretary today about what VA found during the strategic review and what steps VA has taken to implement the recommendations to ensure that future go-lives do not repeat the same mistakes. Regarding funding, which is obviously our primary concern here in the Appropriations Committee, Congress has provided a total of more than $6 billion to VA for this effort just since 2018. Our House passed FY22 bill included an additional $2.64 billion for the program with 3-year availability. This robust investment would allow VA to move forward with planning and executing more go-lives in future years. Earlier this year, however, the VA's Office of Inspector General found that the original 10-year, $16 billion life cycle cost estimate for the program excluded nearly $6 billion of additional IT and physical infrastructure costs. As a result of the Inspector General's findings, I understand the VA is now undertaking a new cost estimate for the program to incorporate all additional costs. Given the delayed implementation timeline and the outdated cost estimate, it is no longer clear to us what level of funding is truly necessary to support the program in FY22 and beyond. I ask that VA take whatever steps possible to expedite this new estimate and to provide us with updates along the way. We can't operate blind in this subcommittee without having real numbers and understanding what your needs are. And at this point, the revised estimate timeline is going to be problematic for us to develop those plans. And the revised estimate will be critical for us to do our job as appropriators. Let me close by saying that it's critically important for the VA to get this transition right. That's the most important thing. From our perspective on the Appropriations Committee, we want to see VA move forward with executing this transition in the most expedient and efficient manner possible. At the same time, however, we must also ensure that VA's transition to the new system is not executed in haste simply to meet an arbitrary deadline. Stumbles will happen when undertaking such an ambitious project, but it is necessary to take the time to address any problems before moving forward, or else those problems will be repeated. There's a reason why we've provided funding with 3-year availability, to allow VA the time to adjust their approach and to get this right. I understand that VA is eager to continue moving forward with additional go-lives next year, but the problems identified at Man-Grandstaff must also be addressed and accounted for in future rollouts. VA has a responsibility to demonstrate improved progress at Man-Grandstaff. This progress will help build confidence in the new system among VA staff and veterans. Much will be riding on the next set of go-lives, and it will be particularly important for VA to be transparent with Congress and the public about the status of those implementations. We cannot lose sight of the purpose of this whole undertaking, which is to improve healthcare delivery and outcomes for our veterans. Deputy Secretary Remy, I look forward to working with you closely on this, and I'm committed to ensuring that the rollout is executed effectively moving forward. And I'm hopeful that with you and Secretary McDonough now in charge, VA will be able to address these problems and improve the rollout moving forward. And I do want to express my appreciation to you and Secretary McDonough for your consistent and open communication on this issue with us so far. I will tell you that, in the previous administration, although I had a good line of communication with the Secretary, he tended to give us notice about things at the very last second, catching us flat-footed, and being surprised is not a fun experience and not responsible. So I hope that we can receive your assurance that VA will continue to have the open dialogue we've had in the coming years. With that, I'm pleased to yield to our ranking member, Judge Carter, who is my friend and been an excellent partner to work with on these and other issues. I yield to you for your opening statement. Judge Carter?
Thank you, Madam Chair. Thank you for holding this hearing. Good morning to everybody. Well, a lot has happened since our last hearing on Veterans Electric Healthcare records in February 2020. However, our goal has not changed. For a seamless health record system that follows a service member from active duty to veteran status. Since fiscal year 2018, This subcommittee has invested $6 billion in making this goal a reality. Yet the department continues to struggle, even while requesting a $2.67 billion fiscal year 2022 for the program. Now, I understand that the technological and cultural changes necessary to implement this new system, they're very challenging. However, they're not unknown or unknowable. Madam Chair, before we provide another significant amount of funding, I want us all to be confident the department is on the right track and will implement the new system within the 10-year time framework as planned. Mr. Remy, thank you for being here to answer questions today. I look forward to this hearing. I yield back.
Thank you, Judge Carter. Appreciate your remarks. And I don't believe we have either Chairwoman DeLauro or Ranking Member Granger here. Not seeing them. Deputy Secretary Remy, your full written testimony will be included in the record, and you are now recognized for 5 minutes to summarize your opening statement.
There we go.
Okay.
Thank you, Chairwoman Wasserman Schultz, Ranking Member Carter, and distinguished members of the subcommittee. I really do thank you for the opportunity to testify on the VA Electronic Health Record Modernization Program. And let me also thank the appropriators for their steadfast support to our veterans, their families, caregivers, and survivors. As you know, I'm a new member of this amazing team at VA, and this is my first opportunity to testify before this committee. I look forward to continued opportunities to engage in transparent conversations with the committee members about this project and other issues at VA. My journey to this position includes serving as an Army officer, as a member of the Senior Executive Service, and twice as a political appointee. In the civilian world, I worked in the C-suite of major enterprises and as a global partner in global law firms. And throughout all of these experiences, I've learned that success of a program is not the sole responsibility of one leader, of one facility, or one vendor. Instead, the success or failure of any program boils down to a partnership between everyone involved, a partnership where responsibilities are shared, accountability is assigned and owned. The Secretary has tasked me with building exactly that type of partnership on electronic health record implementation to create a platform that seamlessly delivers the best access and outcomes for our vets and the best experience for our clinicians and providers. And that's exactly what I'm going to do, regardless of what happened before. And regardless of how long I've been here, I'm here now. And what I want you all to know is that that means I own it all. My goal is to lead this unified enterprise-wide governance effort and make the best use of our resources as we implement this system across the enterprise. I promise I'll be accountable to you and collaborate with you as we move forward. As members of this subcommittee are aware, our handling of EHR to date has failed to live up to this program's promise for our veterans and our providers. I think we heard some of that in the opening comments of the chairwoman. The findings of the strategic review were detailed in prior testimony, and they're reflected in my written statement, and I'm happy to talk about any of those issues here. But what I want to do is to convey 3 points to you in my opening remarks about what we're doing to move forward. First, that we're learning from the implementation mistakes of the past. Second, that the Cerner system works, and we've properly positioned this program for success. And third, we're bringing together all relevant stakeholders, internally and externally, to ensure an effective EHRM deployment. Now, on that first point, let me make clear that I appreciate our employees on the ground at Man Grant Staff. They've worked really hard during very difficult circumstances to make this program successful. And I also take their concerns very seriously. we've taken steps to work with them to address those concerns, to solidify our processes, and to identify lessons learned. And those lessons learned will allow us to take a closer look from additional perspectives at patient safety, at data management, at access to care, productivity implications, and human capital requirements. But more importantly, those lessons learned are helping us make necessary enterprise changes to mitigate similar issues at future sites and to improve the user experience and adoption. The second point is that the Cerner EHR system works. It's been deployed in over 35 countries. It's being used in more than 27,000 private provider facilities and more than 5,900 hospitals, and it's currently being implemented at DoD sites across the nation. So the natural question is, if it works so well in other healthcare systems, why won't it work at VA? Well, I got to tell you, it will work at VA. But we're making a big change from a system that allows for site-by-site differences in how staff do their jobs to one that will provide standardized workflows across the entire enterprise. I believe this change is going to benefit veterans and providers over the long run, but it is a difficult transition, one that goes beyond just the technology of the system itself. And that brings me to my third and final point, breaking down barriers to get the job done. Throughout the history of this project, silos have been unintentionally created within VA. The strategic review showed that our teams weren't working together with the same information and goals in mind. And look, since I've been here, I've even seen some of these barriers myself. But now I believe it's my job as Deputy Secretary to make sure every stakeholder has a voice in the EHRM effort, from veterans to VHA to caregivers, not only in building the system, but in testing the system and training on the system to ensure accuracy before deployment. That's why we're working with Cerner on site readiness activities through our Office of Functional Champion. By embracing change management in a high reliability organization and adopting modifications as outlined in my written testimony, we're going to set up each new site for deployment and success. Madam Chair, I know I'm running out of time, and I want to say that's why our continued conversations with Congress are so important. By making these changes and the others outlined in my written testimony, I think we can. I think we will get this effort back on track. I think EHRM will succeed because success is non-negotiable. It's a must-do, and we're moving forward. VA has done this before. We talked about Vista previously. We were the first integrated healthcare system to fully deploy an electronic health record across our enterprise. And now we'll create the first electronic health record system that allows veterans to access their health care records in one place from the first day they put on their uniform to the last day of their lives. Madam Chairwoman, with that, I'm happy to take your questions.
Thank you so much, Mr. Secretary, and I appreciate your enthusiasm, and I've been appreciative of being able to talk with you and your transparency. But we really need to go beyond enthusiasm. We have to make sure that we are getting really granular about getting this right. And so that's what the purpose of this hearing is. And so look forward to the question and answer. I recognize myself for 5 minutes of questioning, and I put the order of questioning in the chat for members. I'm torn between trying to starting with substantive questions versus the more appropriations-oriented questions, but we'll do a couple of rounds. So I'll ask you the appropriations questions if I don't have time in this round. I mentioned in my opening statement that it was particularly concerning, and I think patient safety is above all, I'm sure you would agree, that the most important thing in this, that there were patient safety issues that arose during the rollout at Grantstaff. The strategic review report cited examples of information that was missing from patient medical records in the new EHR, like current medications, allergies, and other medical history, as well as problems with veterans receiving the correct prescriptions and delays. Those are serious issues that could have real adverse effects on treatment. Fortunately, I don't think that it was caught in time, and hopefully nothing happened that was the result of this problem. But what specific steps have been taken to fix these problems at Grantstaff, and more importantly, to ensure that similar problems don't occur at future sites?
Thank you for the question, Madam Chair. And I do agree that patient safety is incredibly important and paramount in anything we do when we're providing medical services to our veterans and certainly to all patients throughout the medical system. And I appreciate your recognition that there's been no finding of patient harm, but that doesn't take away the reality that there were patient safety concerns. And so what we're doing is making sure that we understand what those concerns are and addressing them, and more importantly, making sure that whatever gave rise to those concerns doesn't happen again. We want to make sure that we learn from what we're doing as we roll out this system. And so we've organized our patient safety concern matrix into 9 domains. And if you will, I can share with you those 9 domains that we can categorize our patient safety analysis around: order management, administration of medicine, pharmacy, suicide risk tracking and documentation, identity, referrals and consults, roles, positions, privileges, ambulatory care, and other patient safety concerns that don't fit into those categories. And as we hear this information, we catalog them into those domains and we examine the root cause and make sure that they don't reoccur.
Okay, but really, how did this happen? I mean, missing patient medical records, um, problems with medications. I mean, what steps are you taking? I don't really understand what you just said, quite frankly, with the 9 categories. That's not an answer that gives me clarity. What specifically are you doing to prevent in the future, and how did this happen that you had examples of the kinds of patient safety issues that became a problem? That should have been the first thing that was avoided. And I realize you weren't there, but like you said, the buck stops with you at this point.
Yes, Madam Chair, and in direct response to your question, um, there was a focus on patient safety issues and trying to make sure that they didn't arise as the system rolled out. There's always a focus on evaluating our systems, our processes, and our application of our techniques and tactics to try to mitigate or avoid
Okay, but
anything that might put a.
I'm asking for specifics. What are you
Yes,
doing to make sure that patient safety in future rollouts are avoided, those problems are avoided? And how did this happen in the first place? Because obviously understanding the core of the problem helps shine a pathway towards preventing it in the future.
yes,
I
ma'am.
need, yeah.
Yes, ma'am. And what I'm trying to explain to you is specifically we've evaluated those things that have arisen, and we've put in place measures to make sure that they don't occur again. Your question that was the follow on to that is, how did they arise in the first place? And that's a reasonable ask. And my response to that is, while we had measures in place, as we do all across the enterprise, it's not infrequent that patient safety issues arise, but we need to make sure that we can tend to them immediately. And that's what we did at Man Grandstaff, and that's what we'll continue to do. So we have people evaluating for issues that might arise. We're talking to our clinicians, our practitioners. We're understanding the concerns that might arise from our veteran community, and we're putting in place uh, um, protective processes to evaluate as the system rolls out and in the training to make sure that we're focused on things that might create a patient safety concern.
Okay, and then my time's expired, but I want to just ask you, how will you ensure us as the Congress that VA will be transparent and public about any future patient safety issues identified and the steps taken to address them? Like I said, I talk to you regularly. I speak to the secretary, but it's not enough just to inform the chair of the VA, the HVAC committee, and the MILCON committee. How are you going to make sure that you are transparent with us and transparent with the public?
Thank you, Madam Chair, and we will continue those communications, and to the extent that it's allowable, because obviously specific patient circumstances are not things that we can disclose publicly, but to the extent that it's allowable, when we provide our reports to the Congress on a regular basis, we will include in those reports an analysis of any patient safety concerns that have arisen.
Okay. and for the public? The
Uh,
public needs
it-
to have confidence in the system.
Yes, I understand. And this is a, again, to the extent that we can provide information, we can identify what we're doing as we roll out this system to make sure that the patients are safe and that the clinicians, the practitioners are able to use the system and keep those patients safe. So to the extent that there are challenges, as we talk about this system, we'll talk about the challenges as well as the successes along the way.
Okay, thank you. Um, my time's expired. Judge Carter, you're recognized for 5 minutes questions. And obviously, the extra time that you might need.
Thank you, Madam Chairman. Before I ask my question, let me thank you, Deputy Secretary Remy, for being with us today, for providing executive leadership on these important efforts. I also want to thank the VA staff who worked through the global pandemic and poor weather during the actual go live at Mann Grandstaff VA Medical Center. They demonstrated commitment and dedication. Please share our appreciation. Okay, the VA is at least 1 year behind schedule. While some delay is due to the pandemic, some is not. Is the VA going to meet the 10-year implementation time framework?
Thank you for the question, Mr. Carter, Judge Carter. It is our intent to meet the 10-year time frame.
Well, that's good. You state the VA is going to conduct enterprise-wide current state reviews. How does this differ from the current process? Is this going to cause fiscal year 2022 and the following fiscal years?
So our plan is to move from what we did previously, which was site by site, to the enterprise-wide evaluation of the readiness of our sites. We've already started some of those current state reviews at our sites in VISNs 10 and 20. And it is our intent to roll out and deploy the EHR system in VISNs 10 and 20 in 2022 and 2023. And that's one of the things that we want to do as we evaluate on an enterprise-wide basis site readiness is to roll out the program through deployment, make sure that any site is ready to receive, that we provide adequate training and testing before we go there so that we don't have challenges that we've seen occur previously at any of the new sites. And as we do that, that is when we're going to obligate funds toward those efforts. As you know, we did not obligate any of the funds toward those rollouts this year, and as a result had a carryover into 2022 because we recognized it would be more fiscally prudent to obligate when we know we're actually going in, and that's going to happen in the first quarter, second quarter of 2022.
Well, it's been described to me that you have a system and everybody's on that system, but also each of these VA sites is kind of an island unto themselves. And so in the way they've operated, it's not always consistent. So there are gonna be challenges in almost every one of these sites. Have you looked through that and through the history of this implementation, which we've been dealing with for 20 years, and make sure that we're not gonna jam up about next year or the year after because of some roadblock we didn't see?
Yes, sir. I think we can, because what we're doing is we're taking the lessons that we've learned already and we're shoring up our processes as we move along. I can't promise you that there won't be any hiccups anywhere along the way. That would be a promise I know that I cannot keep. But what I can commit to you is that we will use the lessons that we've learned previously to enhance and improve our ability to deploy in future locations. And as we do that, we'll become more efficient, will become more effective. And that's how I believe we'll be able to meet the timeline over the 10-year period. Now, we're going to learn some things as we continue to deploy, and I recognize that. And we may be having further conversations in the future about, as the chairwoman described, my optimism and excitement around our delivery and our and the possibilities of delivery. But as we move forward, we'll learn, and we'll make sure that we put those lessons learned into our strategies.
You know, some of us on this committee have been dealing with this issue. Just seems like our whole life, at least for the last 20 years. And we've been encouraged and then collapsed. And so we want this to work. And you've got a great job, and we're hoping you're the man to get the job done. And I'll be praying for you because we need this done right. Thank you, Madam Chairman. I yield back.
Thank you, Judge Carter.
Thank you, Judge. Mr. Secretary, if you indulge me for a second, you have to understand that, and some members on this subcommittee have been dealing with this even longer than me, like the former chairman, Mr. Bishop. The experiences that you are dealing with now are new to you. They aren't new to us. And so we've had a long string of leaders at the VA tell us that the intention is to finish in 10 years. The intention is to be transparent. The intention is to not affect patient safety, and none of that ever happens. So this is a more than 2-decade process that Congress has gone through. And so you are the receptacle for our frustration at the moment, but understand that it's not for lack of experience. With that, Mr. Bishop, you're recognized for 5 minutes of questions.
Thank you, Madam Chair, and I appreciate those comments. Welcome, Mr. Deputy Secretary. We appreciate very much your testimony and your coming to spend some time with us today. As a veteran and a member of Congress, I take a lot of pride in advocating for the care and the quality of our nation's veterans, which is why I'm an active member of this subcommittee. As Vice Chair of the subcommittee, I remain committed to providing VA with the resources that you need to take care of our veterans. But in order to be helpful, we have to have accurate costs and execution estimates from the department. Last year, the electronic health modernization in the VA system was allocated roughly $2.6 billion. This year, the request is for $2.7 billion. Mr. Deputy Secretary, was the VA able to execute last year's allocation? And despite pauses in the program, do you believe that the funding request for FY22 is executable and appropriately programmed, given what you have learned during the review?
Thank you for that question. The answer is no. We were not able to execute on the allocations for last year, and as a result of that, we carried over some into fiscal year 2022. And one of the reasons was, of course, the strategic review, but also because we recognized that at the point in time that we would have needed to obligate those funds, we simply weren't ready to say, yes, we can obligate and we can deliver. We needed more information, more data, and we collectively wanted to make sure that we were being good stewards of the public fisc. And so we thank you for multi-year money to allow us the flexibility to execute on this program in the way that it's intended. But we're also committed to making sure that we do that when it's appropriate. And
well, not to interrupt you, but if you haven't executed on last year's 2.6, why would it not be not fiscally responsible for us to allocate an additional 2.7, which obviously would not be executable either?
So, Mr. Bishop, our plans, in fact, are to execute in 2022. We merely were at a point at the end of the fiscal year that we weren't prepared to do some of the things we are prepared to do in 22 and 23. And so I believe that our plan to roll out and deploy at sites in VISNs 10 and 20, our need to provide infrastructure support to make sure that all of our sites are going to be ready when we deploy this system to those locations. Our recognition that right now, as we do our current state readiness reviews, we have intention to roll out into other visions later in the year. With all of those things together, we believe that the appropriation is necessary to get the work done that we have to get done.
Thank you. Let me ask you this on a different note. According to Inspector General, the VA failed to report the program's true cost to Congress as required by the Veterans Benefit and Transition Act of 2018. What actions have been taken to correct the accounting, and what steps has the VA taken to hold those responsible, those personnel who were responsible, accountable?
So, sir, on your first question, we've got our Office of Management engaged intimately in developing an independent cost estimate, a life cycle cost estimate that will give us greater clarity around the true cost that will include all of the components that need to be included that the IG identified that should have been included in defining the cost associated with our electronic health records modernization program. So we're looking.
Finally, how is the VA prioritizing the cybersecurity as it implements the electronic health records modernization program in the continued use of the legacy programs? How do you reconcile that?
Well, sir, we recognize that for a while, both of the programs are going to have to exist because the deployment schedule will occur over time. And we recognize that we need interoperability in a way that assures that we have cybersecurity protections. And so we've been working toward making sure that we've got a system to do that. We've been talking to the Department of Defense as they're looking at the same issues with interoperability of their system. And we have a team that's focused on cybersecurity issues and evaluating what the risk might be and making sure that we have protections against those risks. So cybersecurity is a clear part of our priorities in examining the program and our path forward.
Thank you. My time has expired. Thank you very much, Mr. Secretary.
Thank you, Mr. Bishop.
Thank you, Mr. Bishop. The gentleman's time has expired. Mr. Valadeo, you're recognized for 5 minutes of questions.
Thank you, Madam Chair and Mr. Deputy Secretary. I appreciate you taking the time for us today. The VA strategic review of the EHRM placed an emphasis on significant upgrades needed to the VA's physical and IT infrastructure. It included that these infrastructure upgrades would need to be completed at all the sites prior to any go-lives and will impact the order that additional VA facilities implemented of the new system. And this is obviously a $6 billion oversight. Can you give us some examples of what these infrastructure issues are and how you are planning to get ahead of them?
Well, thank you for the question, Mr. Valadeo. They are both physical and technological. And we've already started the process of making sure that our facilities are ready to receive this new electronic health records program. We don't want to have a circumstance where our technology equipment is tucked away in a closet and not in a position that it can be effective and it can be maintained. We don't want to have a circumstance where you have laptops or telephones or other technology that's out of date and not prepared to receive.
So, and it seems many of these issues are a result of aging facilities. How did the VA not anticipate these infrastructure needs at the beginning of the project? I mean, again, we're looking at a pretty sizable oversight here.
Sir, what I would say to that is that there was an examination and a recognition that there needed to be infrastructure investment. That infrastructure investment may not have been enough at the time to make sure that we were ready, and that's one of those lessons learned. And so we're moving forward now to make sure that we have the infrastructure we need.
And can you share the criteria you'll now be using to establish which facilities go live moving forward?
So we've got a number of things that we use, and I'm going to grab my notes because this is one of those areas where we have to make sure that we are fluid and we take our lessons learned and we incorporate them as we move along. And so we have a readiness assessment. Cerner has already had readiness assessment tools, metrics, KPIs that go to the technology. We're making sure that we have operational assessment tools and we have readiness assessment tools that focus on training, that focus on information and testing. So we're looking at leadership preparation, leadership engagement, tenure, employee engagement, as we talked earlier about patient safety, the culture, informatics, that's particularly important, staffing levels, physical infrastructure, OIT and medical device infrastructure, change leadership, productivity measures, clinical care measures. We're taking all of those and examining from a diverse perspective how they interrelate. Now, not any one of them is going to happen at the same time, and we have to look at how they interrelate and then talk to the people who are at the facility, who are on the ground, where we might be deploying, and make sure that they are ready and they understand and they've been trained. And we go through sandbox testing exercises to make sure that the technology and the people can sync up and deliver at any of the sites we're going to go to.
So, and this is a little bit down that same path, but do you feel like you've been given Cerner clear directions on what the VA's needs are with this new electronic health records management system? And likewise, has Cerner been clear in communicating their needs with you?
I think we have, but I think it also needs to be understood that as we roll this out at Man Grandstaff, there was, we're in the middle of a pandemic and the communication occurred, but it may not have always been as precise as it needed to be or as complete as it needed to be. That's something that we've been working on from day one, and it's something that we'll continue to work on to make sure that we're clear in terms of what the needs of our clinicians, of our practitioners, of our veterans are to have this system come into their environment and enhance patient care. And that Cerner is clear to us. And I've had a number of conversations with the leadership at Cerner to make sure that they understand what our needs are. But those conversations are also occurring on the ground. But the Cerner is clear to us in terms of what they can deliver and how they can deliver it. And this is a relationship that demonstrates both the VA and Cerner are committed to the success of the program. And one of the ways we can assure that success is by communicating clearly.
All right. Well, thank you. And my time's about up, so I'll yield back the rest of my time. Thank you, Chairman.
Thank you, Mr. Valadeo. Gentleman yields back. Mr. Christ, you're recognized for 5 minutes of questions.
Thank you, Madam Chair. Mr. Secretary, thank you for being with us. Appreciate your presence today. In the July 2021 Inspector General Report on Health Records Modernization Cost Estimates, the IG made 6 recommendations to the VA on how to improve accuracy and transparency. While the VA agreed with all 6 of those recommendations, I share the concerns of the IG that the VA is not actually following through with the recommendation to keep Congress regularly updated on expected cost overruns. Simply following the quote, federal budgeting process isn't good enough. What is the VA doing to fully address the Inspector General's recommendation and to keep Congress regularly updated on cost overruns?
Thank you for that question, Representative Christ. And I'm committed to making sure that we're transparent to you with what's going on with our funding and with our cost estimates. And I know the team at the Department of Veterans Affairs is committed as well. And so we want to make sure that you have the information that you need to exercise your oversight responsibilities to VA. And so, as the chairwoman noted, I've provided regular briefings, and we as a team will provide regular briefings to you and to your staff as we move forward. In terms of the specific life cycle cost, we have hired IDA to do a life cycle cost estimate for us, an independent cost estimate. It's going to take a little while for us to receive the information and data from that estimate. When we do, we surely will provide that to you as well.
Great, thank you, sir. I'd remind you that the budget request generally comes from months in advance at the end of the fiscal year. While a $100 million, $50 million, or even $10 million difference between the budget request and what we appropriate may not seem like much, we're talking about taking care of our veterans, as you know. We need to know if these numbers change and if our end and on our end, they seem to change frequently. Do I have your commitment to keep us more regularly informed as recommended by the Inspector General? I presume so, sir.
Sir, you absolutely have my commitment about that.
Great. Thank you very much, Madam Chair. I yield back.
Thank you,
Mr.
Mr.
Secretary.
Christ, and I appreciate the questions that each of my colleagues have been asking, and I think it's going to be important for us to have more frequent hearings so we can check in with you, Mr. Secretary. I mean, while it's very helpful for me to have the kind of conversations that I have, by phone with you and the Secretary, it feels like the only way we're going to ensure comprehensive information is that we're made aware of comprehensive information necessary for our oversight, that we'll have to have these more frequently. I found that was very helpful when we were trying to bring the CVC, the Capitol Visitor Center, which had massive cost overruns and was very very delayed. So I think we're going to have to take that step. So look forward to seeing you more in the future.
Madam Chair, if I may, in addition to that, I will commit to you that our staff will provide briefings regularly to your staffs to make sure they're up to speed on what's going on.
No, thank you, and I appreciate that, but there's nothing better than direct communication, and as much as we love our staff, we all have a lot going on, and so sometimes we don't get the really the window into where we are, and the accountability is not quite the same as a good old-fashioned hearing with members. So we'll talk about that, colleagues. Let me know if you concur. With that, Mr. Rutherford, you're recognized for 5 minutes of questions.
Thank you, Madam Chair. And Mr. Secretary, thank you for being here this morning and answering these questions. And I'm going to follow up on a couple areas that have already been discussed this morning. I want to talk a little bit about the timeline, as the chairwoman was just discussing. Concerned about some patient concerns that I want to ask you about in the IT infrastructure and cyber resiliency. But on the timeline, the 10-year rollout, are you, first, a simple answer, are you fairly confident on the 2028 deadline now? Now that you've had this time.
Yeah, Mr. Rutherford, as I've looked at the program and examined the challenges that we've had and looked to how we plan to move forward in the future, right now I'm confident that we can meet that 10-year timeline. Let me offer a little more. In talking to other enterprises that have rolled out similar systems, what I understand occurs is after you have these stumbles early on, things become much more efficient in the later years, and you're able to actually deploy in a much more rapid pace. And so it's based upon other lessons learned and our own that I think we can meet the timeline.
Okay, and then following up on the line of questioning that the chairwoman had, so that we can stay on top of the timeline, do you have, or can you provide us a schedule of the timeline so that we know whether we're meeting or you are meeting some of those milestones in the timeline as the rollouts go? Do you have that somewhere?
Sir, we're working on modifying the timelines that we had at the beginning of the program. We
Right.
need additional information and data to do that. Part of that is based upon our rollout in Visions 10 and 20. Part of that is based upon the information we'll receive from our life cycle cost estimate. And part of it, obviously, I think is based upon our site readiness evaluations and how we can move to other Visions and deploy the system. But we are building the new timeline for deployment for all of our sites across all of our Visions within VA.
All right, well, I look forward to receiving that. Let's go to patient safety concerns. You mentioned that you have safety processes that you've put in place. And having been in the executive branch of an agency that was moving into electronic records for a major jail system, I know some of the processes that we had in place to make sure that things like drug interactions were not falling through the cracks. Can you tell me specifically you said there are safety processes that you put in place. How exactly are they making sure that things like drug interaction is just one example in the prescription process is being handled?
You know, we have a multidisciplinary team that's evaluating any potential patient safety issues that might arise. They evaluate those that have been identified. They develop mitigation strategies so that they don't arise again. And we're doing this on a real-time basis to make sure we understand the circumstances that might arise to create a safety issue for our patients, but more importantly, that we provide mitigating factors, mitigating efforts to avoid those things happening again. You know, specifically, these teams are monitoring our clinical workflows to make sure that the integration process of EHR into what our clinicians are doing is not interfering with their ability to care for their patients
So, Mr.
properly.
Secretary, are they running old um, systems parallel with the new system to make sure that things aren't falling through the cracks, or even paper trails? How are they accomplishing that?
Yeah, so the old system is there. It continues to exist as we deploy the new system in its stead. So we'll have a time period when that certainly will be the case. But as we think about the patient safety issues, we try to make sure that we're taking care of the three things that we've talked about previously: people, processes, and technology. And any one of those things could create an environment that might present for a potential patient safety issue. And so we make sure our technology is sound. We look at our processes and go over them over and over and over again to make sure that that flow works properly. And we educate our people to understand how this new system is working compared to how the old system was working, and what we have to do to make sure that it doesn't present any type of unanticipated, well, not anticipated, but it doesn't present any type of patient safety issues that we can't mitigate against.
Thank you, Mr. Secretary. I see my time has expired. Madam Chair, I yield back.
Thank you, Mr. Rutherford. Appreciate your line of questioning. Gentleman yields back. Secretary Remy, I can appreciate that you inherited a mess and that you are in the middle of sorting through the morass. But unfortunately, your questions today, your responses to our questions about patient safety really aren't detailed enough. I realize you probably are doing the best you can to answer them and still sorting through a lot of this. But I think it's going to be helpful for us to have another hearing that specifically focuses on patient safety, where we can have a panel of witnesses from the VA that can provide us with more detailed answers to the questions on the how this happened and on the how you're going to fix it. Because that's what an oversight hearing is all about. And I realize you're doing the best you can to answer, but we're just not really getting enough detail in your answers.
Well, Madam Chair, I appreciate that, and I have spent time with our team and with our clinicians, with those who have evaluated the patient safety issues that were presented at Mann Grandstaff. I've been assured that the process that I've described has resulted in the mitigation of those issues. But certainly, subject matter area experts would be more than appropriate for the committee to
Yes,
talk to.
and I can appreciate that, but we can't just go with trust us, trust me. We can't go with generalities. The purpose of an oversight hearing is for detail. And that way we can make sure that we can reassure our constituents who, you know, when these rollouts make news and there are patient safety concerns and other concerns, that we can reassure them that, you know, we're on the subcommittee that is on top of this, and that we can give them specific answers to questions that they're asking us. So generally, when we have an oversight hearing, and I know in a virtual environment it's more challenging, but usually that there would be multiple folks who would join you to be able to answer more detailed questions when you only have more general information. So we'll just do we'll do another one so that we can dive into this a little bit more deeply. I hope that, and forgive me for jumping in, my colleagues, in between the questions. I try not to usually do that. So I just wanted to try to help us along. With that, Ms. Lee, you're recognized for 5 minutes of questions.
Thank you, Madam Chair, for hosting this important hearing, and I want to thank Mr. Remy for being here today. I've closely been following the rollout of the electronic health record since I came to Congress, and as the chairwoman of the House Veterans Affairs Subcommittee on Technology Modernization, I've consistently voiced my concern about the structure of the financial management of the VA. In his December 2019 testimony before me on that subcommittee, the VA Chief Financial Officer, John Richalski, testified that each administration within the VA had its own CFO, but none of them actually reported to him, which was why I introduced the VA CFO Authority and Collaboration Act last Congress that would require the VA to correct this shortfall and report annually to Congress about whether it had met this requirement. Moving forward, though, I'm happy to see that a VA IT investment board has been created, which is chaired by the Chief Financial Acquisition and Information Officers to oversee all major IT investments and better identify and track funding. However, it's very clear from this hearing today that more needs to be done. And Mr. Remy, I applaud you and the Secretary for conducting a new independent government EHRM cost estimate. However, I need to stress that this should have taken place before the EHRM was rolled out in the first place. For future projects, however, do you foresee utilizing this investment board to create life cycle cost estimates that are then validated by independent entities such as the Institute of Defense Analysis as required by law?
Ms. Lee, it's always our intent to comply with the law, and we certainly are willing to make sure that we utilize this format to do so and incorporate our CFO, who's been incredibly helpful in developing our strategy moving forward with respect to our independent lifecycle cost estimate on EHRM.
So do you and your team have the institutional staff available to stand up the VA IT investment board that delivers on the stated once in a year review of all major IT investments?
Thank you for the question, Ms. Lee. That's something that we're looking at, and I can get back to you. I believe we're adequately positioned to be successful there. But if my team thinks that we need additional resources in order to be successful, I'll certainly evaluate that need and make sure that they have what they need to get the job done.
So you'll get back to us on whether or not you're on track to be able to provide that type of oversight?
Yes, ma'am.
Okay. And what have you and the Secretary identified as the specific deliverables for this board?
I'd have to get back to you on that, Madam Chair. Ms. Lee, to be honest with you, I don't have the list of deliverables here with me, but if I could take that one for the record and make sure that you have the information that you're asking for, I'll absolutely do that.
Thank you. I think that obviously would be incredibly important.
Absolutely.
Finally, just on somewhat unrelated, on page 3 and 4 of your testimony or your written testimony, you talked about the rollout at Man Grandstaff, and that of the 148 issues, there's 2 issues that are still out remaining unresolved. Can you elaborate what those are?
I believe they're technical issues, but I can get that information and get it back to you as well. Ms. Lee, I apologize for not having.
No, it's a pretty specific question. I was just curious about that.
Thank you, ma'am.
All right, and with that, I'll yield the remainder of my time. Thank you.
Thank you so much, Ms. Lee. The gentlelady yields back. Mr. Gonzalez, you're recognized for 5 minutes of questions.
Thank you, Madam Chair, and thank you, Mr. Secretary, for for this hearing today. I just want to reiterate what the chairwoman mentioned earlier. Specifics are extremely important, and the more we can drill down on that, the more we can find out what areas we need to push on. The VA's health record will contain a veteran's entire health history. The security of these systems is vital to public confidence and veteran well-being. The VA is drafting a new enterprise-wide cybersecurity strategy for the first time in 3 years. Can you tell me when that's going to be rolled out?
My understanding is that it's still in development, and you're asking for the specific date. I apologize, I don't have the specific date for rollout, but it is something that is including the exploration of all the new architectures that are associated with cybersecurity, and it is a top priority for us, Mr. Gonzalez. And so, thank you for recognizing it, for acknowledging it, and for bringing it up. I know Mr. Bishop asked similar questions about cybersecurity, and as I've spoken with the team about this, I understand that it's something that will be rolled out in the very near future.
Yeah, I was told September, and here we are in October. And if you don't have a cybersecurity strategy, it's very difficult for you to implement cybersecurity across the department. And I'm very concerned with that. And every month that goes by, every year that goes by, that strategy becomes more and more obsolete. So it's so critical that we get going. This isn't a nice to have. We're already seeing these cyber intrusions in every aspect of our lives, right? Whether just throughout. So it's only a matter of time. It's already been happening, but it's only a matter of time before the VA becomes the next target in that. And I won't go into specifics, but I really would like maybe at a later time or follow up is to get specifics on what is working and what is not working in particular when it comes to cybersecurity. Oftentimes people won't highlight the things that aren't working. They won't highlight. They'll talk about all the wonderful things that are happening. But even if it's a private conversation, I would like to know, I think it'd be helpful for this committee to know where some of the landmines have been so we can help. We can get ahead of the problem in general. My next question is, folks, veterans in El Paso in particular have been long forgotten. And one of the things that concerns me is them in particular. The subcommittee appropriated, very excited, the subcommittee appropriated $150 million to construct a new veteran health care center in El Paso. How does the VA's implementation of the Cerner millennia differ in a new facility versus updating software and hardware as an existing facility? I understand we're updating some, but this is going to be a new facility. What is the plan incorporating that into this, in particular the Cerna into this new facility?
Thank you for your question, Mr. Gonzalez, on this issue, because it's important for me to convey to you that as we find facilities, and you're identifying a facility that's going to be brand new, that are ready, that we can go through the process of determining the readiness to receive the electronic health record system, we can move forward smartly there. We're trying to do this, though, on a VISN by VISN basis. And so what you've just identified is a need to make sure that we can be flexible enough to evaluate a circumstance where you don't want to deploy technology that's obsolete. I understand that, and you want to make sure that facilities that are ready to receive and embrace and deploy and operationalize our new electronic health record system can do that in an effective way, and that's something that we'll certainly look forward to exploring with you and with the new facility and the VISN.
Speaking of VISN, my last question here. My last question is, VA is aiming to have the electronic health record roll out in all VA medical facilities by 2028, as we discussed. Texas is in VISN 17. Texas is home to more than 1.4 million veterans. Where is VISN 17 in this schedule of rollout?
Mr. Gonzalez, as I mentioned earlier, we're still working through the overall rollout for all of the VISNs across the country. And so I can't tell you today where VISN 17 fits. What I can tell you is what we're prepared to do in 2022 and 2023. And we're evaluating, we're engaged in our current state readiness across all of our VISNs to determine when those visits might be ready, and the VAMCs, the medical centers within them, would be ready as well. When we have that data and information, I'll make sure that we provide it to you.
Okay, thank you. That's important to 1.4 million veterans in Texas. Thank you, Mr. Secretary, and I yield back, Madam Chair.
So,
Thank you, Mr. Gonzalez. The gentleman yields back. I'm going to start a second round. Feel free to let me know in the chat if you have questions for the second round. Otherwise, I'll just go through the order that we asked the first round questions in. Mr. Secretary, I mentioned the findings of the Office of Inspector General on the program's life cycle in my opening life cycle cost estimate in my opening statement. The VA underreported nearly $6 billion in additional costs that will be required to fully implement the new EHR. And I know that the original cost estimate predates your time at the VA, but this is a serious problem that has to be addressed. We obviously want this program to be successful, but it's difficult for us to appropriate funding for a program when no one is certain how much it will cost. Your testimony estimated that this cost estimate will take about a year to complete, which is unfortunate and inconvenient to say the least. But as we await a revised life cycle cost estimate, will the FY23 President's budget request be adjusted to reflect any additional costs for the EHRM program? And I'm going to again ask you that the VA take whatever steps possible to expedite this new estimate and to provide us with the updates along the way, because that's going to be critical for us to do our jobs as appropriators. So
I
if you can answer that first question.
Thank you. I understand, Madam Chair, and we're working as hard as we can with IDA to try to get the life cycle cost estimate completed as quickly as possible. But you note it may take upwards of a year. We also are evaluating what we might need to do for FY23. Obviously, we're not at a point yet where we can specifically determine whether or not there are going to need to be adjustments, and we'll work through the process of working with OMB and moving forward and examining what's going to be in the president's budget. But EHR is one of the areas that we're focused on in determining what funding is needed for FY23.
Okay. I mean, obviously, asking for more money when you aren't able to spend the money you have, and you have a 3-year window to do so would not be helpful. And also getting us that information as soon as you are aware of it, and have a better window into it would be helpful too. Now, I understand that any funds that we appropriate in the final FY22 bill will support the preparation work for go-lives that'll occur at sites 1 or 2 years from now. And we're obviously committed to ensuring that VA moves forward with executing this transition, in the most efficient manner possible. And want to remind VA that funds for this program have been appropriated with a 3-year period of availability. But given the delayed status of the rollout and the outdated cost estimate, it's really no longer clear what level of funding is truly necessary to support the program in FY22 and beyond. Now, your testimony asserts that VA's FY22 request remains unchanged. Can you help us understand why the department's full FY22 funding request of $2.66 billion for EHRM is still necessary in light of the new developments and information that have emerged since VA first developed the FY22 budget? Obviously, circumstances have changed dramatically. I'm not sure why you would need all that money given the circumstances.
Thank you, Madam Chair. And yes, this is something that we spent a fair amount of time looking at and examining and trying to determine what's needed to move forward. And as I've mentioned previously, our plan is to roll out and deploy the electronic health record system through VISNs 10 and 20, possibly to a couple of other VISNs during that time period. And we need to make sure that all of those sites that would be ready to receive the system have the infrastructure that they need to have in place, and we take the proper steps to train and test and evaluate. And so as we look at the funding needs for FY22, and we've kind of done the analysis here, notwithstanding the fact that we did not use everything in FY21, we do believe that the funding needs remain constant because of the work that has to be done to prepare to roll out at future VISNs. As I've said to you before, if that becomes, if that changes at any point in time, we certainly would inform the committee. Look, I understand the skepticism that the committee might have for the VA's desire to have a continued funding in this space when we didn't use the money that you gave us already. And what I've been working with the team on is trying to make sure that we have specifics that we can share with you that will show where the money's going to go as we move forward. We have a general idea. We have some specificity around what the components of the cost will be to roll out to the subsequent VISNs. I want more specificity. You want more specificity. And as we develop that, I promise we'll give it to you.
And I really do trust that you will do that, but but you have to appreciate that you're telling us on the one hand that it's going to take about a year for you to get a handle, your arms around what the true revised cost will be. You've asked for $2.66 billion for this year. You didn't spend all the money we gave you last year. You have a 3-year window to spend the money that you have now. So it makes it difficult for us to defend that amount, maintaining that amount without clarity and specificity on what you'll be able to use it for and whether you'll actually be able to spend it.
I understand, Madam Chair, and what I'm committing to you is we continue to develop our strategy here, but I believe that the strategy that we have for rolling out in FY22, based on the data and information that we've gathered and the focus on the business that we're going to deploy, is going to require the funding that we're requesting.
Okay, well, I look forward to continuing those conversations. Thank you. My time's expired. Judge Carter, you're recognized for 5 minutes.
Thank you, Madam Chair. Well, I've got some ideas here. I certainly agree with my chairman that we need to stay on top of this. We've been doing this for 20 years. We haven't rattled your cage as much as we need to. And I would suggest a monthly assessment of what's going on these health records by hearing. I would suggest that you said you've put together a readiness checklist. I want to know what metrics, as you report to us, what metrics and performance measures the VA is using, any changes that are going on. Does the VA have nationwide assessment of readiness, or is it individual? When will you have one? What will you share? When will you share with the committee? Do you have any sense yet of what is the hindrance sites from being ready to implement? Those types of things we'll be hearing about every month, and then get a reason why and how can we help, and then we're willing to spend our money. I have nothing against you personally, but I have been doing this very thing since 2004. And I'm ready to stop. This is the year we ought to build a fire under the VA. And so I'm recommending what my chairman put forward, and I would like to suggest a monthly basis.
Judge Carter, as usual, we're singing from the same song sheet, and that was what I envisioned as well. So my plan would be for us to schedule monthly hearings, and that way, at the very least, you and I can get a a transparent and regular update, and obviously, hopefully, the majority of the committee will be able to attend as well. I think that's going to put us in a much stronger posture of being able to be aware of the developments as they proceed. So that's my plan.
Yeah, Mr. Secretary Remy, we are on your team, but we got to start moving the ball and moving it. Thank you, Madam Chair. I yield back.
Thank you, Judge Carter. Help us help you, Mr. Secretary. That's what we're trying to do here. Okay, from the looks of who is still in the meeting, my understanding is Ms. Lee does not have any further questions, and Mr. Rutherford, do you have any further questions? If so, you're recognized for 5 minutes.
Thank you, Madam Chair. Yeah, Mr. Secretary, I'd like to follow up, and it goes in line with the question that we've already covered a little bit. But when you talked about the rollout of VISN 10 and 20 and FY22, is there do we know the cost for the latency issues in the IT infrastructure? Do we know the cost for each of the VISNs to go in and fix that, those infrastructure problems? Is there a schedule for that? And can you tell me what the overall cost of that is going to be? And is that being laid out separately, or are you going to look at that as you do the rollout for each one of the VISNs, like 10 and 20?
Yeah, Mr. Rutherford, that was one of the items that I think was identified in the IG report, or one of the reports, to make sure that we were including those infrastructure costs in the overall cost of the program, and to make sure that we understood what the infrastructure cost would be over the life of the program. That part will be handled through our life cycle cost estimate analysis. But with respect to what we're spending on infrastructure right now, that's information that I'll go back to my team, take that one for the record, provide you the data on how we're spending on infrastructure, because that is a key component of our spending for FY22, to make sure that we have the infrastructure, both physical and technological infrastructure, in place to deploy at these new sites.
And so to follow up, and Madam Chair, I love this idea of these monthly follow-up meetings like this, so that Mr. Secretary, we can learn these things as they happen, because I know a lot of the cost, it's difficult to project because you don't know what you don't know, right? And I understand that, but the quicker we understand what is being uncovered during these rollouts, the quicker we can help you, I think, make sure that you're getting everything that you need from us to help mitigate whatever challenges you may run up against. So I'd like to see, now you spoke about VISN 10 and 20. Do we have an estimated cost yet, or have on the IT infrastructure for those two VISNs as you go into this rollout?
I can go back and determine whether or not we've divided it up in a way where we can look site by site by site for the infrastructure cost. And if we have that information, get it back to the committee.
Okay. I would love to see that, so that when we do start this rollout, I have something to compare it against, what you anticipated and what reality turns out to be. And so that would help us understand what we might anticipate in the future even. So, and with that, let me ask one last question, Mr. Secretary. Our third-party payees at Man Grandstaff, I heard that we were significantly behind on those third-party payers. Can you talk a little bit about that? Are you familiar with that challenge, and what are we doing about it?
I'm sorry, Mr. Rutherford, I'm not. But I can go back and take that question and make sure that whatever happens and whatever's happening in that circumstance, we provide you with an update.
Okay, yeah, I would love to have that information. I was told that the third-party providers, that our payments to them were significantly behind. I don't know if that's true or not, but it's just something that I've heard.
I had not heard that. So are these subcontractors?
Correct.
I will look into that.
Thank you. With that, Madam Chair, I yield back. I see my time is up.
Thank you, Mr. Rutherford. I want to thank Secretary Remy for joining us this morning, and appreciate the really significant challenges that you're facing in trying to unravel all of the challenges. We know it's not easy, and we know you inherited a mess, and it is a cumulative mess of multiple administrations. So, like I said, we want to help you, and I'll yield to Judge Carter for any closing remarks as well. You're on mute, I think, Judge Carter.
Thank you very much, Madam Chairman. And great minds think alike. But we've got to get this fire going. It's just been smoldering for almost 20 years.
Yeah.
And a lot of men and women are suffering because of it. So we need to get it done. And I think I'm confident this secretary can do the job, but we've got to, I love what we're thinking about. And we'll visit some more on this, you and I.
Absolutely. Mr. Secretary, thank you very much.
God bless you.
Oh, sorry, the gentleman yields back.
You're back.
Thank you. Sorry about that. Didn't mean to talk over you. That concludes this morning's hearing. I want to thank everybody for their participation today. This is an incredibly important